Okay, on to Streptococcus. So we're still in Chapter 19. Chapter 19 is gram-positive pathogens or clinically important gram-positive. So we're talking through the cocci. So we did Staphylococcus last time, on to Streptococcus today. After exam 4, we'll get more into the gram-positive rod-shaped organisms like bacillus and infections that they cause, Clostridium. So let's look at some characteristics of Streptococcus. This, hopefully, if you're in lab, looks a little bit familiar. When we gram stain Streptococcus from a broth, then we often see these nice, long, elegant chains. Okay, it shows up much better when you gram stain from a broth than if you did from a plate. All right, so we've got, again, gram-positive cocci, typically arranged in chains. Okay, just like staph, I don't think I mentioned this for staph, but they are non-motile, so that means they don't have flagella. I don't think there are any cocci that have flagella. I've looked for that and haven't found any, so that's probably a pretty general rule. I don't know of any exceptions to that. They are also non-spore forming. Remember, that's fairly rare in the bacterial world. Next, after the exam, we're going to get into some interesting spore formers. Mostly, they are considered facultative anaerobes. Okay, so most Streptococcus are facultative anaerobes. There are a few that are considered true anaerobes. There is some nuance here. Usually a facultative anaerobe would be able to use oxygen or not use oxygen, so they're respiring aerobically as well as either fermentation or anaerobic respiration. I believe that most Streptococcus only do fermentation. So why are they considered facultative anaerobes? Because some of their virulence factors are better expressed in the presence of oxygen. So that's a little nuance. Those virulence factors give them a better chance of surviving, causing an infection, establishing themselves in host. So there's a little nuance there. And some of them are considered capnophiles. Okay, that means that they grow best in a little higher concentration. I should put the brackets there, that means concentration of CO2. Okay, so when we grow them in the lab, we have a CO2 incubator where we can provide that environment. A little lower tech solution is we put our plates in a candle jar. So that's just a big jar where we light a candle, close the jar. The candle not only uses up the oxygen, which isn't really that important, but a byproduct of combustion is carbon dioxide. So get a little higher concentration of carbon dioxide, and that's will make some of our streps grow better. All right, our Staphylococcus were catalase positive. Streptococcus are catalase negative, so that's a big test that helps us tell the difference between staph and strep. They actually have a different enzyme to detoxify hydrogen peroxide. Don't memorize this equation here, but this is the peroxidase enzyme, what it does. It uses the electron carrier NADH, and what we end up with, water and the oxidized form, NAD. All right, so I don't know if there is a peroxidase test, but this is, again, what allows streps to be considered facultative. There are a couple different tests that we use to tell our Streptococcus organisms apart. And those of you in lab, again, you have the advantage there because you've actually seen hemolysis patterns on blood agar. So one way to tell a streps apart is by looking at these hemolysis patterns. So sheep's blood agar, has some sheep in it. Have some blood in it. Blood is a particularly rich medium, lots of nutrients in blood cells when those are lysed. So 3 different hemolysis patterns that we see with our streps. An alpha hemolysis is considered a partial red blood cell hemolysis. It lyses the red blood cells open, but only partially or doesn't degrade the hemoglobin within them. So that's why you get kind of a greenish, more kind of greenish brownish color change there. Beta hemolysis is total red blood cell destruction. So you could read through this plate if you held it up to a window. You can really see through there quite easily, that yellowish change in the medium around the growth. And gamma hemolysis, it's a little harder to see this one there on the plate. There's really no change in the red blood cells. It doesn't lyse them at all. All right, so that's one way that we classify streps. Another totally different way that doesn't have anything to do with hemolysis is based on Lancefield groups. So this is named for some work that Rebecca Lancefield did back in the 1930s, I believe. And she discovered that there were some carbohydrate surface antigens on Streptococcus. So here's a cell. We had these sugars on the surface of the strep that were fairly unique. So typically carbohydrates aren't very antigenic, but she could make antibodies that would recognize, certain antigens. So she put them into groups based on these sugars. And this slide is not for you to memorize. In fact, for some reason, it cut half of it off here, but you should have that in your notes. Again, don't memorize this. Some of the groups only have one organism in them. For example, Group A, Strep Pyogenes, that's the only organism in that group that has those specific sugars on its surface. And sometimes we like to combine these 2 classification systems. So, for instance, Strep Pyogenes, you'll sometimes see the abbreviation GABHS. That stands for Group A beta hemolytic strep. Okay, that's, again, science loves abbreviations. So that's the same thing as Strep Pyogenes. Group B, we're going to talk a lot about Strep Pyogenes. We're going to mention Streptogalactii as well. Some of the groups have multiple species in them, like Group C. And I just noticed this the other day. This organism, Streptogalactii, which I don't know anything about, but it's listed in several different groups. What's going on there? Well, it has the Group C surface antigens and what else? The Group G and the Group L. It has all of those. Okay, so this is not a perfect classification system. In addition, there are some of the streps that don't have any of these carbohydrate surface antigens. Okay, so like strepmitis that you used in lab and strep pneumoniae, they don't have those surface antigens, so they are called non-Lancefield groups. Okay. All right. So let's talk about some virulence factors. Well, first we'll talk about Strep Pyogenes briefly here, and then talk about some virulence factors of Strep Pyogenes. So, like I said, it's beta hemolytic Group A. Where do we find Strep Pyogenes? Sometimes can be normal microbiota in the throat, so like the nose area, as well as the skin. Probably not very commonly going to be, again, normal microbiota. How do we pass that among each other? Typically have to be in pretty close contact, so respiratory secretions, so that's within about a meter of each other, coughing, sneezing, laughing, talking, that sort of thing. This is sort of a plain slide, so I decided to include a picture of, there's a website that you can go to called Giant Microbes, and you can buy these plush, bacteria and viruses and things like that. So you can peruse that, but this is a Strep Pyogenes. It has you can see it's a diplococci here, at least that's the way they draw or, make it. You can see the knife and fork on it. That's to represent that Strep Pyogenes is the cause of flesh-eating disease or necrotizing fasciitis. So we'll get to that in just a minute. All right, let's start with some structural virulence factors. So Strep Pyogenes, again, some of the other streps have these virulence factors. These are ones commonly seen in Strep Pyogenes. Not every strain of Strep Pyogenes is going to have every one of these tools in its arsenal. But again, these are the things that make it successful in establishing an infection in our bodies. Typically, they're encapsulated, and they have a special kind of capsule. Remember, we have hyaluronic acid in our bodies. That's I've talked about that as the glue that kind of holds our cells together. Well, their capsule is made of something that we often see in our bodies, so our immune system is not likely to recognize it as being foreign. So that helps the organism evade phagocytosis. Our neutrophils, our macrophages, again, aren't going to recognize that. Toll-like receptors aren't going to recognize anything that's going to say this is worthy of being phagocytized. Here's an antiphagocytic factor that we talked about before, M protein. At least we mentioned that back in chapter 14. Remember, here's a nice picture here. We've got the M protein on the surface of this cell. Here's a cell that obviously doesn't have that M protein. So I have here that it destroys C3 convertase. It's actually best at keeping the alternative pathway of complement activation from happening. It basically binds to one of the factors there that we didn't really talk about that's necessary for that, again, alternative pathway to start. So basically less complement is, being activated, so you're not going to get the opsonization, the increased inflammation from that pathway. Okay, there are actually two different kinds of M protein. There is a rheumatogenic, I don't know what you call it, kind of M protein, and a nephrogenic. Basically, this gets into some cross reactivity. So when we eventually form antibodies to M protein, some of our antibodies, the ones to the rheumatogenic M protein, are going to cross-react or have the potential to cross-react with heart muscle. And that can cause an autoimmune condition called rheumatic fever. So we'll talk a little bit more about that in a few minutes. The nephrogenic M protein are antibodies, again, very similar to proteins that we have in our kidneys. So here our antibodies cross-react with cells in our kidneys. And we'll talk about the effects that can have. Okay. All right, some exo enzymes that Strep Pyogenes commonly would have. Some of these things, we talked about complement now, so we can talk more about this. C5a peptidase, all right? So you should recognize that as a complement fragment that's going to increase inflammation, which of course would increase chemotaxis of cells, immune cells to the site. So this is going to neutralize C5a. Okay, remember that's a chemotactic factor. And streptokinase. We talked about staphylokinase, same kind of job, lyses blood clots. Okay, and that, what good does that do? That's going to aid in just the spread of the infection. Okay, so it's going to just spread more rapidly through damaged tissue. And another exoenzyme, remember exoenzymes are working pretty locally. They're not going to spread throughout the whole body. One that has two different names that we call it streptodornase, DNase. If we call it by that name, it's a little bit easier to remember what it actually does. Remember one of the ways that neutrophils act on cells. Neutrophils can phagocytize, they can degranulate, and they also have this method of killing called NETs, neutrophil extracellular traps. All right, so if the Streptococcus can make DNase that basically degrades the NETs, remember the NETs were basically a neutrophil expunging its DNA and making this kind of sticky network to kind of immobilize pathogens. The DNase can basically break out of those nets, so it kind of neutralizes one way that neutrophils have of killing. So it's a little disheartening, we have all these things like complement and, neutrophil action that helps us fight infection, and pathogens have weapons to fight back at that. So it's a little bit disheartening. I should mention, I forgot, streptokinase sometimes is given to heart attack victims, especially if it's their first heart attack. It's going to break up a clot, perhaps. It could be causing that heart attack. What good does lysing blood clots? Well, if you've got a wound where our blood is clotting, if the strep can, break through that, it's going to be able to, again, spread and the infection. A few different exotoxins that Strep Pyogenes is capable of making. Streptolysins, this is just a specific kind of hemolysin. Okay, and these are going to act not only on red blood cells, but other kinds of cells like white blood cells as well. All right, so you might have talked about in lab there's a couple different kinds of streptolysin, and you don't need to memorize this for me, but organisms that make streptolysin O are only able to lyse red blood cells when they're not in the presence of oxygen. So when you streaked your Streptococcus out here, you were instructed to stab down in the auger a little bit, back up here where we got lots of growth, to get some areas where there's less oxygen. Get the organism growing where there's less oxygen so you can see the hemolysis better. Okay, other organisms have a streptolysin that is not sensitive to oxygen. So you're going to see beta hemolysis wherever there's growth on the plate. Some organisms have both, some have one or the other, or neither one. All right, so again, blood cells are a really rich nutrient medium. So that's one reason that organism would make this exotoxin. I mentioned that they can act on white blood cells as well. They can actually, this is a dirty trick, cause lysosomes to release their digestive enzymes after the organism is phagocytized and before the lysosome fuses with the phagolysosome. So if it's expunging its digestive enzymes in the cell, then it can actually cause the white blood cell to die. So again, kind of a dirty trick. And lastly, it's fairly rare even with Strep Pyogenes, but some strains are able to produce this erythrogenic toxin. Only some strains, it's only strains that have been infected with a lysogenic phage. Okay, so reaching back to our viral replication, remember if a cell is infected with a lysogenic bacteriophage, that's a virus that's going to integrate into the host cell chromosome, and that can actually cause, remember we talked about lysogenic conversion. So it's actually able to change the phenotype in some cases. So basically, a Strep Pyogenes that's been infected with a lysogenic phage, then a specific phage would be able to produce this erythrogenic toxin. So only ones, again, that have been infected. It is a superantigen, so like toxic shock syndrome toxin, it causes the just overstimulation of T cells, lots of inflammation. The inflammation damages the membranes of blood capillaries under the skin and causes this bright red rash all over the body, followed by high fever, and that's a condition that we refer to as scarlet fever. So show you some pictures of that pretty soon. Much more rare now than what it used to be. So late 1800s, early 1900s, this was a very scary thing. Lots of mortality associated with scarlet fever. All right, some infections caused by Strep Pyogenes. Let's start with the skin infections. Impetigo, remember we talked about Staph aureus causing impetigo. Strep Pyogenes can cause that infection as well. It's difficult to tell by looking at it which organism is causing it. Strep impetigo is often a little bit crustier. It's supposed to be anyway. But remember, this typically stays localized. So this is typically not an infection that is going to turn life-threatening. Okay, but again, need to treat that to try to get rid of it to make sure that the skin doesn't scar. Erysipelas is getting a little bit more serious. Symptoms here, we have raised red lesions. Sometimes that's on the face, can be on the trunk or legs or arms. And there's really a whole range. This can be a very superficial infection, or it can be deadly. It kind of depends on the strain. It's often described as this orange peel consistency. So the skin looks a little bit tough, maybe a little bit slightly pitted. Like I mentioned, extremely high fever. Who's susceptible to it? It usually begins when the skin is damaged in some way, maybe due to an insect bite or some kind of wound or burn, or maybe just a person has eczema. Even something like athlete's foot and you're itching it, and so it starts with some kind of mild trauma. And lots of complications. It can go systemic. Patient can go into shock. Even necrotizing fasciitis can progress into that. So again, this is something you definitely want to seek treatment for. Now, sometimes it's difficult to tell the difference between erysipelas and cellulitis. Cellulitis also has the potential to be very serious. Cellulitis sometimes is caused by Staph aureus as well, although we didn't mention it there. This doesn't have anything to do with cellulite. So, fat that we get in certain areas of our body, that's nothing to do with that. Typically, cellulitis is moving deeper into the connective tissue. Again, same kinds of risk factors. So, group A strep enters through a break in the skin or some kind of trauma. Hands, face, or legs is most common here. So we see some localized inflammation, fever as well. So you can see here, this is the infected hand. We've got some swelling, redness, and pain. Something that shouldn't be ignored. All right, because again, this can spread to the bloodstream and certainly become life-threatening. So seek treatment for that. All right, worst of the worst skin infections then, certainly necrotizing fasciitis. If something's necrotic, that means death of tissue, and your fascia is kind of the connective tissue that holds all your organs and everything together. So again, this is the flesh-eating disease. Mortality around 50%, so very, very serious infection. This is a strain of Strep Pyogenes that has some exo enzymes that allows it to basically digest the connective tissue. Early symptoms, it's very treatable if you catch it early, but those early symptoms are things like flu-like symptoms, maybe a little pain in the area like your arm or your leg with or without a little bit of redness. So the early symptoms are not something that would immediately tip you off that you had a very, very serious infection. Okay, once it's very fast moving, so typically the treatment is cutting out the diseased tissue to try to keep ahead of it. Okay. So moving beyond skin infections, other Strep Pyogenes infections, the first one that I always think of is streptococcal pharyngitis, so strep throat. Probably most of us have had this maybe a few times in your life. Some people seem to be much more susceptible to it than others. It's transmitted through respiratory secretion, so typically you have to be in close contact with somebody to get this. This pyogenes, that prefix pyo means pus forming. All right, so one sign that sometimes we see is those pus pockets on the tonsils. It's not always present, so don't assume, oh, it can't be strep. I don't have those pus pockets on my tonsils. And you can get strep throat if you don't have tonsils. I've only had it once in the 15 years since I've had my tonsils out. So for me, it's made a huge difference as to whether I get strep throat or not. But it's causes a really severe sore throat. So there are other kinds of infections that would cause a sore throat. Lots of sore throats are viral. Like I always have kind of a sore throat when I have a cold. So don't assume, hey, I need antibiotics, I have a sore throat, right? There's lots of other things that cause it, but it's a pretty severe sore throat, usually accompanied by fever, sometimes accompanied by abdominal pain and even nausea and vomiting. And sometimes I know for our kids that's kind of thrown us off, that think, oh, they have some kind of stomach bug just because they're vomiting, but that can happen with strep throat as well. Lymph nodes are typically swollen. Remember, we talked about that. A swollen lymph node is typically a sign of infection, that your immune cells are all, excuse me, mixing. We got, more swelling, more inflammation. So strep throat, if you suspect that you have strep throat, you should seek treatment. And if you don't want to pay the money to, have a doctor check that out, they do have rapid strep tests. Like at Meyer, you can go in, you can do it yourself. And then I think if it's positive, they will prescribe an antibiotic for you right there. You want to treat it if you have strep. You don't want to let it go, because there are some secondary infections that are associated with an untreated Strep Pyogenes infections, as well as some autoimmune complications that are rare but can happen. All right, so bronchitis, pneumonia can result, and as well as scarlet fever. So let's talk a little bit more about scarlet fever. And again, we consider this a complication of strep throat. So, you got a painful sore throat for a day or two, fever, go get it checked out. Before my daughter was able to talk, she broke out in a red rash like this, and we didn't realize, that got us to take her to the doctor, but we didn't realize that it was scarlet fever because she wasn't able to tell us how badly her throat hurt. So That red rash is caused by that erythrogenic toxin that we just mentioned. Remember, that's a super antigen, so we see this, horrendous rash that starts on the trunk and moves out from there. That really gets your attention. Another sign is supposed to be a strawberry tongue, so a bright red tongue. Strains of Strep Pyogenes that carry this toxin, like I mentioned, they're not circulating as often now. So strains of Strep Pyogenes, like I said, are less likely to cause scarlet fever now, but they seem to be more likely to spread in the population than what they used to. And back in like the late 1800s, early 1900s, this was a killer, especially among children. Now that we pasteurize milk, that was one way that it spread, through unpasteurized milk. So now that we pasteurize milk, that's one of the reasons we don't see it as common. We believe that this was an infection that Helen Keller had that caused her to lose her sight and hearing when she was a toddler. And then we have some longer-term complications of strep throat that I alluded to before, some autoimmune complications. And it's estimated that about maybe 1 to 3% of untreated strep infections, or sometimes partially treated, so somebody takes antibiotics for a few days and then stops, of untreated Strep Pyogenes infections would lead to one of these autoimmune complications. So not common, but in the days before we had antibiotics to treat strep infections, you would know somebody that, had a problem, probably more than one person. Okay, so rheumatic fever, don't confuse this with rheumatoid arthritis, which is a chronic condition. Rheumatic fever is temporary, but it can have some lasting permanent effects. All right, so we usually show up a number of weeks after a Strep Pyogenes, a strep throat infection, and especially if it's not been treated or, again, partially treated. Most common in children, it can cause nodules under the skin. So here's an example of a nodule at a joint. So it can cause an abnormal electrocardiogram. That's because the antibodies that we formed to that rheumatogenic M protein cross-react with proteins found in our body, and most commonly in the joints or the heart valve, so like the mitral valve. Okay, so that would give an abnormal electrocardiogram, painful, swollen joints, fever. Again, we don't see this a lot anymore because we take antibiotics for strep. And Streptococcus is one of the few organisms we have left that we see very little resistance to antibiotics. So if that would change and our antibiotics are not working as well, then we would see a resurgence of this for sure. So that heart valve damage can be permanent. All right, another complication, again, cross-reactivity with the nephritogenic M protein, is acute glomerulonephritis. All right, so this is targeting the kidneys. There was one of my colleagues that used to teach in BMS. Every time he got strep throat, it would land him in hospital because his kidneys would shut down. So even though he treated it, some people seem to be susceptible to this somehow. So basically, when those antibodies target areas of the kidney, it obstructs the blood flow, and your blood pressure goes way up, and urine output gets low. And this, damage is potentially permanent here. So something that's, again, don't be afraid to go to the hospital if you start to see these effects. What can we do in terms of treatment for both acute glomerulonephritis and rheumatic fever, we typically give immunosuppressive therapy. Another S in there. Okay, so giving antibiotics isn't going to help with our immune system targeting our own antigens, our autoantigens. Okay, so anything that would dampen down our immune response. All right, a few words about diagnosis and treatment in general. How is a Strep Pyogenes infection detected? Or how do we identify Strep Pyogenes? Again, more for the benefit of those of you in lab, just to kind of underscore some of the things that you've been learning about in lab. Of course, Strep Pyogenes is beta hemolytic, which looks something like this on a blood agar plate. We use a bacitracin disc to differentiate between some closely related organisms like Streptogalactii. You can see Pyogenes is over here. It's sensitive to that A disc. We can also use, like I mentioned, a rapid strep test. Now, again, this detects carbohydrate surface antigens unique to group A. Unfortunately, it can't tell the difference if you have some Strep Pyogenes as normal flora in small amounts. It could detect that. So rather than, oh, you have a strep throat infection. But if all the symptoms are there, sore throat and all that, then typically antibiotics, would be prescribed. The gold standard is growing the organism up and, again, throwing the A disc on there. But unfortunately, that takes a couple of days. So if you're sick, you don't want to wait that long, and typically they will prescribe you antibiotics. Any of the beta-lactams, people that are allergic to beta-lactams typically would get azithromycin to treat that. All right, so another one of our strep organisms, I'll just mention kind of briefly here, one that you used in lab, Streptogalactii. It's also beta hemolytic. It's in Lancefield group B. It also forms capsules, and the interesting thing about the capsules of Streptogalactii is that this is considered a T-independent antigen. So remember the significance of that when our B cells recognize the capsule of Streptogalactii, that can activate B cells to differentiate into plasma cells and start making antibody directly. So it's a fast response, but remember, this is a response that doesn't work well in very young children, say below age 2 or so. So adults don't have any problem with Streptogalactii. It's typically normal microbiota, pharynx, that means the nose and the throat, large intestine, vaginally. So because it can be normal microbiota vaginally, we test women late in their pregnancy to see if they're carriers of Streptogalactii. You might have, if you've ever had a baby, you've had the group B strep test. And if you are a carrier, they will treat you to try to get rid of that, because if babies pick up that organism during birth, it can cause some very serious neonatal infections. So newborns, you don't want your newborn to get infected with anything, let alone something that can cause meningitis, sepsis, pneumonia, really serious infections. So with good prenatal care, we are able to basically mitigate the risk of this. So, okay. Moving on. Remember, we said there was a few organisms that didn't fit into any of those Lancefield groups. A few of our alpha hemolytic streptococci, like Strepmitis, is considered to be in that Virulence group. There's a root here that I think in Latin that means green. Maybe that has something to do with green. But remember, when something's alpha hemolytic, it can have kind of a greenish tinge on that blood agar. These organisms are typically not too invasive to the rest of the body. We find them as normal flora in the mouth, and so unfortunately they do contribute to tooth decay. Kind of a nasty picture there. Okay, they make a nice big capsule that allows them to stick to our teeth. We see some of them in some other parts of the body as well, but again, it's the tooth decay that's kind of the primary thing that we think about with strep mitis. Strep pneumonia, on the other hand, is a lot more serious. This is another alpha hemolytic strep, and again, doesn't fit in any of those Lancefield groups, with a letter on it, A, B, C, whatever. So we've named it to be its own group in a pneumococcal group. Okay, and this organism used to be referred to as pneumococcus. And at one point in the 80s, they recategorized all the streps and decided that that pneumococcus was actually should be considered a streptococcus. Okay, so usually presents as diplococci, and a good number of us just have a little bit strep pneumoniae as normal flora, in our nose or upper respiratory tract. Okay, so, we could be passing it unwittingly to somebody that's, had, kind of a dampened immune response. What are some virulence factors here that make it successful? Very, very big capsule. Okay, when you look at this organism growing on a blood agar plate, it looks slimy. Great big colonies, mucoid is the way we like to describe that. And if you remember back when we were talking about horizontal gene transfer and transformation, this is the organism that Griffith did his experiments on to demonstrate that cells can take up DNA from dead cells. Okay, you had the smooth group and the rough group. The smooth group of strep pneumoniae had capsules, and the rough group couldn't make capsules. Okay, so a lot of different variation in that capsule that's made it difficult for us to treat it or make a vaccine for it. There is a vaccine that covers a number of those different types of capsules. Again, thinking about Griffith's experiments, it's essential for virulence. So a strep pneumoniae cell that can't make a capsule is not going to be able to establish itself in our bodies. It's just too susceptible to our, macrophages and neutrophils that would phagocytize it. Okay. Another virulence factor, phosphorylcholine. Okay, this is a secreted chemical that acts and helps it to invade our cells. It's kind of a dirty trick. The release of it stimulates our cells to actually engulf the bacteria. So cells lining our respiratory tract basically get signals to take up the strep pneumoniae. Strep pneumoniae can also secrete an enzyme called pneumolysin that causes a lot of cell damage, again, in the respiratory tract. So binds to cholesterol in our membranes, creates a pore in the cell membranes of our ciliated epithelial cells in our respiratory tract, and can actually cause the lysis of those epithelial cells. So again, we see a lot of targeting of cells on our respiratory tract, as well as an enzyme called IgA protease. This destroys that isotype of antibody we have that's most present on our mucous membranes. So again, it's an enzyme that can, we see that warfare, that arms race of, oh, we have antibodies, oh, then the organism has this that fights those antibodies. Okay, so lots of targeting, again, cells of our respiratory tract. What kind of disease do we see caused by strep pneumonia? Well, the most obvious one is pneumonia, and it's a very common form of bacterial pneumonia. Of course, there's lots of organisms that can cause pneumonia. We talked about Staph aureus able to cause pneumonia. There's many other ones. But with this particular kind of pneumonia, we see lots of fluid in the lungs, pain, certainly, and diagnostic. Often, a doctor can tell the crackles and pops that they hear through their stethoscope that can tell you that a patient might be struggling with pneumonia. It can also produce kind of a bloody cough. Cyanosis, that means the patient's extremities are starting to have kind of a bluish tinge because they're not getting enough oxygen through, the action of the lung damage. Okay, pretty treatable, typically given at least a couple of different antibiotics just to make sure it's going to take it out. Okay, so we'll get to that in a minute. Other infections caused by strep pneumoniae, in addition to sinus infections, I didn't really mention that one, but ear infections, otitis media, much more common in young children because they have a narrower ear canal, get poor drainage sometimes, so young children seem to be more susceptible. The bacterial infection here sometimes can follow some kind of viral infection that's weakened our immunity a little bit. And of course, meningitis, very serious. Again, different organisms that can cause meningitis. We saw Staph aureus can cause it. We're going to talk about a gram-negative cocci that can cause meningitis soon. But it is one of those organisms that's able to cross the blood-brain barrier. That chemical that we talked about before, phosphatidylcholine, is thought to help facilitate that movement. Lots of inflammation caused, lots of, even if the patient survives, getting lots of permanent damage like brain damage, blindness, deafness. Thankfully, it's less common now because we have a pneumococcal vaccine. So very important to vaccinate young children, infants, so they're less susceptible to meningitis and, of course, the ear infections, as well as older adults because they are much more susceptible to having serious pneumonia. And that vaccine is called PV13, or you've probably heard this advertised on TV, excuse me, Prevnar 13. Okay, it's what's called a conjugate vaccine. That means, so it's a vaccine to the capsule, which carbohydrates, typically not very antigenic, so they combine that weak antigen, so capsular antigens, with some stronger antigen as a carrier, usually some kind of protein, to elicit a stronger immune response. And actually, they take a protein from the organism that causes diphtheria to elicit that strong immune response. Okay, so usually there's a Prevnar 13 is that pneumococcal vaccine for infants and older adults. There is a different vaccine for people between the ages of 2 and 64 that are at higher risk. So usually they have some other condition. Okay, and it's a little different form of the vaccine. Okay, so diagnosis, treatment. Really don't want you to, there's so many different ways to treat this. It's not necessary to memorize. There's a whole host of different antibiotics. Usually use a combination of a couple different antibiotics. Again, if it's a more serious like pneumonia or meningitis. Here's what strep pneumonia looks like on a blood agar plate, and that opticon disc, we see a nice big zone around opticon, and that distinguishes it from strep mitis that would be resistant to opticon. All right, so yep, that's all I got for you for Streptococcus. After exam 4, we will move on with some gram-positive bacilli and different infections there.